Good afternoon, everybody. We're going to go ahead and get started. I don't have anybody that I have to yell at to sit down. Everybody was very cooperative. Thank you. There's a legacy of that in our department that I don't know if I'm courageous enough to continue. This has been a terrific day of research, the Schilling Research Day, honoring our residents and our faculty, and a number of fantastic presentations. And now we get to the climax, and we have Dr. Caprice Greenberg here from the University of Wisconsin. And Dr. Greenberg is professor of surgery at, as I call it, the other UW. She's the Morgridge Distinguished Chair in Health Services Research, Director of the Wisconsin Surgical Outcomes Research Program, and Vice Chair of Research in the Department of Surgery. And so in short, and don't take this pejoratively, she is the Wisconsin Dave Flum.
I'm more like
there is a difference. She's nicer and possibly smarter. And I say possibly because Dave Flum is perhaps one of, if not the smartest person I know. And so to be in the same category with him, I have to put some qualifiers on it. So we're really happy that you're here. There was actually quite a bit of competition for having Dr. Greenberg visit us. Our Women's Council, who presented grand rounds last week, wanted to invite Dr. Greenberg. Our research program wanted to invite Dr. Greenberg. Everyone wanted her here, so we're really thrilled that you're here. Dr. Greenberg is here as our 24th annual Schilling Visiting Professor. And most of you have some familiarity with the Schilling legacy that we have. And this Research Day and Visiting Professorship is a legacy of Dr. John Schilling and a gift from Helen Schilling, his wife, to honor his time as chair of this department. And to further the tradition of excellence in patient care, teaching, and research in the Department of Surgery. And I think we can see evidence of that today. And when we look at the list of individuals, starting with Dr. Judah Folkman, who was the first Schilling visiting professor, you can see a legacy of incredible surgeon leaders and surgeon scientists. And if we just think at the last couple of years, with Dr. Diana Farmer here last year and Dr. Melina Kibbe here the year before that, you can see an incredible history of leadership and research as surgeons, and Dr. Greenberg is exactly in that mold. So we're extremely happy to have you here. Dr. Greenberg did undergraduate and medical school at the University of Chicago, did a general surgery residency at Brigham and Women's Hospital. Sometimes I take some exception to that, having trained in a partner institution, partner in quotes, at a competing place across town. She also got her MPH at Harvard and did a surgical oncology fellowship at Dana-Farber. And most of you are aware of her research in comparative effectiveness and patient-centered outcomes, particularly relating to cancer care. And she has 17 current grants, 130 papers, peer-reviewed papers, innumerable speaking engagements around the world and visiting professorships. And maybe most telling is a list, incredible list of mentorship of students, residents, and junior faculty. And it's been alluded to a couple of times, but an example of Dr. Greenberg's leadership is her presidency this past year of the Association of Academic Surgery, and her presidential address, Sticky Floors and Glass Ceilings, is a great YouTube hit, as we've noted. I do have a competing YouTube hit, but it's not nearly as intellectual as yours. And accomplishments aside, however, when you talk to people that know Dr. Greenberg well, what they remark about her is her willingness to give of herself, her time, to provide support and mentorship to students, residents, and junior faculty. They remark about her intellect, her humility, and that she's just a great person to have as a friend and colleague. So it's nice to have you here so that we can be part of being your friend and colleague. Dr. Greenberg is going to be presenting on surgical coaching, the intersection of surgical education and quality care.
So thank you so much for that incredibly kind introduction. You know, it's been just amazing being here. It's been incredibly humbling, and I've been trying to figure out, you know, what it is about this place that makes it so unique. And I think there's been two things that I've really picked up upon. Number one is the caliber of the people and the research that you're doing. You know, when I applied to residencies, I applied to 50 residencies, and I got 49 interviews. The one interview I didn't get was here. and now I see why. There's just no way I could compete with what I saw today in terms of the polished presentations, the incredible, inquisitive, and rigorous research that you guys are doing. It's really remarkable. But the other thing that's really impressed me is the way that you guys are taking this disparities issue head on. Whether it's Dr. Mayer's initiative with the American Surgical Association, or whether it's the incredible comments we heard from Gianna earlier, or the portraits that we have over in that room, I think that you guys should be proud. I think that you are leading the country. And I've been talking about this issue a lot at a lot of institutions, and this is the place that I've been most impressed with in terms of the conversations that you're willing to have and how difficult they are. So I hope you can continue to move things forward. So really, it is just my honor and my privilege to be here today, and it's been a wonderful couple of days, and I'm looking forward to tonight when we get to celebrate all of your guys' accomplishments. So before I start, I do have just a couple of disclosures. We did get some funding from Covidian to study coaching, but most of the funding that we have to study coaching actually comes from federal grants. So we are trying to do this in an incredibly rigorous way. I will say that my talk today is probably going to be a little bit more theoretical than some of the other talks that you've had at this lecture. And it's because this stuff is really hard to study, and we've been spending the last 8 years sort of building the foundation and the groundwork on which we're hoping to build a really rigorous research program. So with that, I want to start with just an overview of what I hope to cover today. So I want to start by identifying the gap. I want to talk about the definition, the theory, and the principles of coaching, what I mean by it, and why it's different than what we've been doing. I think that's one of the biggest criticisms that I get when I talk about this is, oh, you're just using a fancy new word for something we've been doing for a long, long time. I want to talk about how surgical coaching in particular has been operationalized, and then give you an update in terms of the state of the science. So let's just start with the gap. And I want to start here because this is the other thing people tell me, is there's no way anybody's going to do this, okay? And if you look at the numbers as a country right now, and you look across all medical specialties, we spend over 42 million hours and over $2.4 billion on continuing medical education. And there is not an iota of evidence that what we're doing has anything to do with the quality of the care that we provide. Yet, everybody wants me to show them effectiveness data that coaching influences outcomes. And so I just want to start with the baseline of kind of where we're at, right? And I think if you talk to most people, and you know, I just went through the recertification process a couple of years ago, and I spent a lot of time, I spent a lot of money, I relearned how to take care of patients in the ICU, I relearned about vascular disease, I relearned about trauma. I'm a breast surgical oncologist. None of that has anything to do with what I do every day. And so what we're trying to do is to come up with a way that we can spend that time and we can spend that money in a more efficient, more practical, more personalized way that can actually influence what we do. Because none of us have any extra time to waste in a day. And so the futility of some of these CME activities, and particularly the maintenance of certification, came to a head over the last couple of years. And you've probably seen some of the other specialties that have basically started to say, we're just not going to do it. Right? Because it's a waste of our time. And I think that our board and our college and our professional organizations have actually been much more forward thinking than some of these other specialties. And so we haven't had the same backlash in surgery yet. But I do think that we need to be proactive about making sure that what we're doing is aligned with what we know about adult learning theory. And so what do I mean by that? If you think about the way that we've approached continuing medical education, it's really been based on a summative evaluation, right? So you go through a residency, you go through a fellowship, you take your board exams, and you come out and you're a fully mentored surgeon, and nobody really critically looks at what you do, right? You don't really get much feedback after that. We participate in CME, but it's teacher-driven, it's didactic, and it's a mass, right? Unfortunately, you guys are all at my mercy for the next 40 minutes, right? You have no control over what I'm going to show you, yet somehow you're supposed to participate in activities like this and take this information and magically transmit it back and make changes to your practice. And we know that that's nearly impossible to do. And so the goal with all of this is competency, right? We're trying to find the people that aren't meeting the basement. And I would argue that's not really good enough anymore, right? We need to start to raise the bar for everybody. And so there's been a big push, and I think Ajit Sachdeva was the first one to talk about this idea of continuous professional development, but it's this idea that we really want to participate in lifelong learning. Formative evaluations are much, much more valuable than summative evaluations. At this point in my life, an A means nothing to me, right? I want to know what I'm good at, and I want to know where I can improve. And so what lifelong learning requires is it requires that the student or the learner be the one who drives the agenda or the initiative. It's interactive, right? I'm bringing a ton of experience and knowledge to the table, and I have to be able to interact with the person who's trying to facilitate my learning. And it's distributed, so it has to take place over time. And so the goal there is really to teach ourselves how to do better self-assessment and self-improvement. And as a result, our goal is practice modification and improving performance throughout our careers. So a couple of years ago, this paper came out, and most people have seen it, so I'm going to go over it quickly, but it came from the Michigan Bariatric Surgery Collaborative. And I want you to pay a lot of attention to this because it's going to come back later when I talk about the R01 that Justin Dimmick and I have together in Michigan. But basically, what they did in Michigan is they have a collaborative similar to SCOPE, and they asked all the surgeons that participate in the collaborative to send in a video of themselves doing a bariatric surgery. And then they sent it out to all the other surgeons that participate in the collaborative, and they graded each other using OSAT. So they graded them from a 1 to a 5, where a 1 is where you should be when you finish either your residency or a fellowship, and a 5 is the best bariatric surgeon you can imagine. So 3 should kind of be the average surgeon in practice. And so lo and behold, and not to anyone's surprise, there was pretty big variation in people and how people were scored in terms of their technical skill. But the really critical point of this paper was that they were able to link this to outcomes because of the incredible value of having these quality collaboratives like you guys are fortunate enough to have. And what they showed was that there was basically a 4-fold difference between people who had ratings in the 2 to 3 range and people who had ratings in the 4 to 5 range. That is a huge effect size based solely on the technical skill or the surgical skill of the surgeon doing the procedure. So this represents an untapped area that we can potentially target to try to improve surgical outcomes. So in thinking about, well, how do people improve performance? This was when I was in Boston, and right around the time that Atul wrote his article on surgical coaching, we also published our first paper showing sort of the empirical qualitative studies showing that surgical coaching actually could work as a concept. Right? So they use it in sports, they use it in music, they use it basically in all other professional disciplines. Yet in surgery, we never really thought about the fact that we could use some help in continuing to improve throughout our careers. So definitions, theories, and principles. So let's start with the definition. There's a whole bunch of definitions out there, but these are the 2 that I like the best. Unlocking a person's potential to maximize their own performance. It is helping them to learn rather than to teach them. And it's providing objective and constructive feedback to help someone recognize what works and what can be improved and inspire them to maximize their potential. So the focus is all on the learner. This isn't about somebody coming in and telling you what to do. This is about somebody coming in and helping you figure out what you could do differently. So I do want to make a quick distinction, though, because I think one of the things that turns people off about coaching is that they have this idea of expert coaching. There's lots and lots of different terms that you can use to break down different types of coaching, but expert coaching has a role in surgery. I really think it does. I think that we can use coaching principles, and we have a paper that we did where we looked at using coaching to facilitate video-based review for residents and fellows, and showed that the teaching is very different and much more resident-led and much more individualized when you employ coaching principles. And there's also a role around teaching new procedures, and I'm going to give you an example of a project that we did which used expert coaching in that realm. But really, when I talk about surgical coaching, I'm talking about peer coaching. And peer coaching is when peers who are often at a similar level of knowledge engage in an equal non-competitive relationship. It involves establishment of goals, observation of a task, self-evaluation, and feedback to improve the task performance of the person who is undergoing the coaching and to support change in their practice. So I've talked about adult learning theory a little bit, and we know a lot about how adults learn, and adults don't learn very well from PowerPoint. So adults really learn when they're active participants in their learning. They need to have supported self-directed learning. They need to have facilitated self-reflection. And the goal is to allow the person who is being coached to identify their own goals and to pursue their own goals. The content has to be relevant, it has to be tailored to their past experiences, and it has to be related to their current experiences. And constructive feedback plays a really key role in this. And constructive feedback, again, is one of those things that we're not so good at. We talk about it a lot, but nobody really teaches us how to do it, right? I mean, I think about the way that many of us teach in the OR. Yep, no, don't do that. Nope, switch sides. Right? I mean, it's very, very non-descriptive, and it's very, very difficult to learn from that. So how do we think about constructive feedback that might be different? It's descriptive, it's specific, and it's non-judgmental. You're describing what you're seeing, and you're describing the implications or the outcomes of what it is that you're seeing. It's focused on those on observations and those impacts rather than on assumptions or inferences or the way that you perceive what's happening. It's trying to stay objective. And most importantly, it's followed by the opportunity for the person receiving the feedback to ask questions and engage. Good constructive feedback should lead to a conversation that gets deeper into why it is that somebody does what they do. And in fact, many of our coaches come back to us and say, I learned as much when I'm in the role of coach as I do when I'm in the role of coachee. Part of the goal of what we're trying to do is based on some work from Anders Ericsson, and he talked about this thing called the Proficiency Plateau. So if we think about everyday skills like walking and talking, right? I have a toddler at home, and the amount of mental energy that goes into him being able to walk and talk, right? We couldn't function like that. We don't think about how to do those things anymore. And Ericsson argues that we can do the same thing with more complex tasks, right? We know many clinicians who get into habits based on everything's working, everything's going fine, it's the way I've always done it, right? We get into routines, and people talk about how, over time, clinical medicine can become less challenging because we sort of know what we're doing, right? And we stop questioning how to do it better. And so the goal with coaching really is to see if we can move from this arrested development to this idea of expert performance. And experts are people who are in a continuous learning state. Many of you may have read Daniel Pink's book, Drive, but I think he describes this phenomenon really well. It's this idea of the asymptotic curve of mastery. So the further that you move along in terms of experience and practice, the better you get, the closer you get to perfection, the smaller the increment you're going to improve, but you can always improve, right? And the example that I like to use here is Steph Curry, right? He is already the best, yet he is constantly coming up with new ways that he can practice his shots so that he can get better, and he can get better, and he can continue to push that boundary of what is the maximum level, how close can you get to perfection. And that's what we're trying to do with coaching, is to get people into that continuously learning mindset. And when we go into the OR, we really go into the OR as an expert, right? Patients are putting their lives in your hands. And so we know the answers when we go into the OR. And so because we know the answers, we often show a little curiosity in the workplace, in the OR. We rely on habits, routines, and rules, and we feel competent, complete, and comfortable. What we want to do with coaching is to provide a safe environment where we can take off that expert hat for a little bit, and we can look at things a little bit differently, and we can question things, and we can wonder about the answers. We can show great openness. We can challenge assumptions and beliefs and whether or not we're doing the right thing, right? I think, being in this department and questioning whether or not mediastinoscopy is the right thing to do, That takes courage. That's questioning. That's being a continuous learner. And I think a lot of what we've seen today are the number of people in this department that are continuous learners, that are continually trying to figure out how can we do this better. And so what we're trying to do is to figure out how can we take that and apply that in a more routine way to practice for all surgeons, regardless of the setting in which they practice. So how does this work? What am I talking about? So I was really fortunate when I moved from Boston to Wisconsin, because I moved from a place that didn't really have college sports to a place where you really couldn't turn around without seeing red. And so I had access to some of the best coaches, right? Bo Ryan, he was Big Ten Coach of the Year like countless times. So I was able to spend some time with these people and with their athletes and watching them in practice and trying to understand what makes a good coach. How do they coach? How do they motivate? How do they interact? And then we went over and we went to the School of Music, and we found people that coached musicians, and we looked at how they did it. And then we went over to the School of Education, and we looked at how they did it. And then we went and found an executive coach and recruited her to be on our team so that we could understand what executive coaching is about and what principles and what practices could we pull from there and pull into what we were trying to do. And so we tried to bring that all together, and we put together this thing that we called the Wisconsin Framework. And we wanted to just identify for people who wanted to start thinking about applying coaching principles to surgical performance, what are the things that you need to think about? So you need to think about the coaching context, right? Do you want to do video-based coaching, or do you want to do live coaching in the OR? Do you want to do peer coaching, or is this expert coaching? What's the level you want to do it at? Is it institutional, regional, or national? And I've been involved in projects at all those different levels. And then we wanted to identify the things that we could control, right? So what was more important, the coach's knowledge and experience or their interpersonal skills? And how do we find people who have the right mix of these two to train as coaches? And then what do we need to know about the coachee? What are the things that we want to be able to be aware of and coach to, but not be exclusionary? So the operative context or the surgeon's characteristics. And then finally in the middle, how do we train people to actually do this? Like, what does it mean to do coaching? One of the things that we needed was a framework or a way to kind of think about activities of coaching. And this is primarily based on the work of Steve Ewell and some other folks. But you can break surgical performance down into technical performance, interpersonal skills or non-technical skills, and then cognitive skills. And these are incredibly artificial, right? The reason I have those big blue arrows pointing in both directions is because it's really hard to talk about technical skill without talking about decision making. They're so intertwined, you can't separate them. But it gives you a scaffolding for these conversations, and it gives us a scaffolding for analyzing these conversations. The one thing that was really missing here that we didn't realize until we started analyzing coaching sessions was the issue of stress management. The issue of recognizing when things are starting to not go well in the OR and you're starting to get stressed out, and then figuring out what to do about it, how to cope with it, how to engage your team in it, right? Bringing in those interpersonal skills, and how to get out of that situation. And that was something that our participants were bringing up in these conversations. And once again, it interacts with your ability to continue on with the case, your decision making, all of those things. And right around the time that we realized this, there were a couple of papers that actually came out that started to talk about the need to expand our conceptualization of surgical performance to include stress management. So an effective coach, what's an effective coach? Based on talking to all of those people, we realized that your technical skill probably doesn't have a whole lot to do whether or not you're going to be a great coach. You have to be technically competent, you have to be respected by your peers as a good surgeon, but you don't have to be the best surgeon. What you have to be is somebody who is non-threatening, somebody who has good communication skills, somebody who's able to adapt. This concept of adaptability comes up again and again and again. The ability to read the person you're working with and figure out what it is that they need. So a quote from Bo Ryan that really stuck with me. He said, there are some guys on my team that I need to get in their face and I need to yell and I need to swear. And there are other guys on my team that if I did that, they'd be a puddle on the floor. So those guys, I have to put my arm around them and talk to them in a soft voice as we're walking into the locker room at halftime. And you need different ways that you interact with people based on what it is that they need. Again, when you're a coach, you're in service of another person, and you have to understand what that person's needs are and what that person's style is. You have to be able to motivate, and you have to understand the field. So this issue of video versus real time, this comes up a lot. I personally am a huge believer in video-based coaching. I think it's really the best way to do it. I think there are lots of issues with real time. The first thing is that video allows you to see yourself in practice. And so for those of you that are MIS surgeons or do laparoscopy, you see yourselves operate all the time. For those of us that do open surgery, it's much, much harder, and we don't actually watch ourselves operate that much. So I would encourage anybody who hasn't videotaped themselves and watched themselves operate to do it. It's incredibly educational. And it's even more educational when another surgeon's sitting across the table from you, breaking down your performance with you. It confers a time savings of 50 to 80%. Again, getting back to this efficiency thing, right? Nobody really has the time to take a whole day and go and scrub with somebody else. But what you can do is take an hour when you're getting together for other reasons and sit down and look at a video and figure out how you can improve what is being done. It removes concurrent responsibilities from the person who's being coached so that they can fully concentrate on assessing their own performance, and it mitigates medical, legal, and credentialing complexities for the coach. So video capture in the OR, we've come a long way. We have a long way to go. Some institutions have phenomenal capture and can get multiple views from multiple cameras, all synced with audio, and it's fantastic. For other people, we're trying different ways of putting together GoPro cameras and head cameras and different ways that we can record what's happening in the operating room so that they can review what's happening. So state of the science. So this is a study that comes from Ara Darzy's group over in the UK. And what they did was they randomized laparoscopically naive medical students to either the traditional way that we go through simulation, which is basically to give people access to the simulators, to give them a presentation, to show them how to do it, let them practice, and then to see what happens with their performance, versus a intervention group where they had video-based coaching review, and they used a model called GROW, which is a coaching model, and basically showed that they were able to improve performance, whereas people who went through the more traditional route really didn't improve their performance over the course of the study. This is a study from Canada, which had a similar approach. They randomized, this is actually in residents who were on their bariatric surgery rotation. They were randomized either to go through the program the traditional way or to have video-based review where they were coached by one of the minimally invasive surgeons. And at baseline, based on, so OSATS is a measure of technical performance. This is a bariatric specific measure. And then they also looked at technical error. And you can see that at baseline, there was no difference between the control and the intervention group. But after going through the coaching program, there was significant improvement in performance for the intervention group, but not for the control group. And you can see across the groups, again, post-intervention, statistically significant improvements on all of these measures. So a little bit worrisome that they go through their whole rotation and there's no improvement in their performance without coaching. So this is how we're currently training our trainees. Perhaps the more interesting thing, though, to me, was trying to get at this mechanism of what is it about coaching that seems to be working? How is this working? And they looked at the correlation coefficient between how the individual trainee judged their performance and how they were judged by an expert panel, and showed that there was no correlation for the control group in how they viewed their performance and how they were viewed by experts. But after going through a coaching program, correlation coefficients of 0.8 and 0.85 are actually pretty good. So again, surgeons, there's lots of data on this. We don't really have a very good grasp on how good we are as surgeons. Once you go through a coaching program and somebody sits you down and points out what you do well and where you can improve, at least for trainees, you get an increase in your correlation and a more accurate assessment of where you really are. Now, in the same edition of Annals of Surgery, there was a somewhat disheartening study that also came out of Canada that was a qualitative study and asked practicing surgeons if they were interested in coaching, and basically unanimously they said no. And so Mary Klingensmith and I actually wrote an editorial that pointed out that all the reasons that people said they weren't interested in coaching was because there was a misperception of what coaching means. So people talked about, for example, the fact that surgeons in academic practice feel they have sufficient technical skill in their defined set of procedures and want to concentrate on other areas of their career with their limited time. And so Again, I would say that coaching is more efficient than some of our other approaches, so it's going to increase the time that you have, and it can also be applied to other areas of your performance. So for example, interpersonal skills. Concerns about authority and image, and this is again why I really am an advocate for video-based coaching and also making sure this is rolled out in a non-punitive way. And then finally, this idea of loss of autonomy. And again, we don't really have control over our learning agenda. But what we're talking about with coaching, you set your learning agenda completely and you decide where you need to focus. So let's talk about peer coaching. When we thought about how to start rolling this out, one of the things that we did was we went to the literature to see if there was anything that we could use as evidence for how to start. And we found this study that had been done in pediatrics where they looked at rolling out quality improvement programs through state and regional organizations. And I think that many of our state and regional societies are really struggling a little bit in what their identity is. And many of these organizations actually started years ago to sort of be a self-policing entity, a place that we could make sure that each other were safe, that we were taking care of good patients, part of our profession, right? Part of being a professional is making sure that your profession is up to standards. And so by partnering with regional and state organizations, you can kind of get back to those origins. In addition, you can engage physicians from across practice settings, right? If we try to do this through the AAS, for example, we're going to get a whole bunch of academic surgeons and nobody from private practice. But the private practice surgeons tend to participate more in these regional societies. And then this issue of regional collaboratives for quality improvement. Again, things like SCOPE and the Michigan Bariatric Surgery Collaborative. Lots of data coming out of those groups, lots of feedback, lots of performance and benchmarking, but trying to think of what are the interventions, what do we offer somebody when they get that performance report back that says that you're a low outlier? How do we help them to improve? That's what we're trying to do. So we developed a quality improvement initiative with our Wisconsin Surgical Society, which is also our state chapter of the ACS. In order to figure out how to identify our coaches, we actually decided to try peer nomination. So the idea was that we know who are the people that we would trust if we needed help in the OR, right? Who is the person that can come in and not judge you, but figure out where you're at and figure out how to help you get out of that situation. We also found that a lot of the people were people that get the calls from the community surgeons who are really struggling. Who do they feel comfortable calling? Who's not going to make them feel bad about themselves, right? Who's going to be supportive? We put them through a 4-hour training program. We gave them some resource manuals, and then we recruited 10 surgeons to participate. They video recorded an operation based on their individual goals. So if they were interested in interpersonal skills, they had to record the whole room. If they just wanted to work on technical skills, they could just record the field. And the goal was really to have this happen 4 times over the course of a year. These are the resource training manuals. We had one for the coach and one for the coachee. And then we also developed videos to help with training. And I'm just going to play a short clip of this just so you get an idea of what it looks like.
So you got through that initial difficult portion, and you were talking about another area that you kind of struggled in terms of progressing. You want to fast forward to what you're talking about there?
So here the residents are all pretty good at isolating the cord structures, and so there's not much to see here. So if we fast forward to really, I think the next part that I tend to struggle with is the actual mesh placement itself. And so, I've never really loved the wheat lanners. I think they tend to just be more in the way, and the ones that we had where I trained never really held all that well, and so I've never been a big fan of using them. But so at the same time, then I usually end up sacrificing one hand to try and hold things open while I'm trying to follow with their suture on the mesh, and then trying to hold the mesh in place. And so I've kind of all these different things I'm trying to do, and I just feel like I end up with a finger in the surgical field holding the mesh down, and another hand doing something that's probably.
I'm going to stop there in the interest of time, but obviously on a budget, so had to use people I had some influence with. That's my husband, for those of you that don't know. And then, I just want to give you an example of how this might work if you wanted to address interpersonal skills.
So far, most of our discussion is focused on the technical aspects and the kind of cognitive approach to these cases. Let's talk a little bit about your interpersonal skills and how they relate in the operating room. How do you feel like you get along with folks?
I think I'm a pretty easygoing guy and tend to get along with most people in the OR.
So you walk into the OR, tell me what kind of things you do.
So usually I just go and help the nurses and start prepping the patient.
Okay. They appreciate that, I assume.
I think so. I hope so.
So maybe we can start by looking at the beginning of your case,
Yeah,
when,
sure.
when you first walk into the room. Stop it there for a second. Your thoughts?
It does look like kind of everyone else in the room maybe tensed up a little bit, which I don't think I've ever really noticed before.
And do you think it's something from the past, or is it something going on that day?
No, I mean, I think, when getting to the OR and usually cases start late, I maybe get a little frustrated and just try and move things along to try and get back on time, and maybe that's kind of a weird environment for everyone.
Okay. And I think that's an important thing to look at, too, because, clearly the team is there to work with you, and maybe there's some things we can identify.
Skills on their communication skills and interpersonal skills than signed up to work on their technical skills. And I haven't quite figured out if that's because that's less threatening to sort of our identity, our core identity as a surgeon, or whether it's because people are really struggling with some of the cultural changes that are going on in the OR and really trying to figure out how to adapt to that. But regardless of what people signed up for, they ended up talking about all of this stuff during these hour-long sessions. They're incredibly rich. So the way that the program works, as I mentioned, is that our coaches and our participants each go through separate training programs and then come together. They go through the pre-call, and then they go through this series of video-based reviews. I just want to go over a little bit of the data. All of the data from this is perception-based data, okay? This is Wisconsin. Unfortunately, we don't have a collaborative yet. I'm working on it. It's one of my goals. But the participating surgeon's motivation. So why did people sign up to do this? The biggest reason was expectations to learn from the experience, their responsibility to maintain and improve their skills as a surgeon, and personal enjoyment from reflecting on their own practice. Particularly this middle one, I remember very vividly at one of our surgeons who were in private practice who was talking about how starved he was for interaction, right? We all take for granted that we could walk into the next room and ask our partner how they would handle some case. Many people are really isolated out there in practice and don't have the ability to do that. And he said, if you told me there was a coaching program where I could get feedback on my performance and I didn't do it, I wouldn't feel comfortable looking my patients in the eye and telling them that I was doing everything I could do to make sure that I was taking the best care of them I could. And so these numbers are on a scale from 1 to 5. And as you can see, people are really very devoted to trying to learn from the experience when they sign up. Why did the coaches participate? Primarily the coaches, and that's not up here, but primarily the coaches participated because they enjoyed interacting with other surgeons. They enjoyed trying to help people to get better. So we asked the coaches after they went through our training, were they ready to go out and do this? So again, if you think back to that framework that I showed you, there's basically 4 main things we want them to do. We want them to set the goals, we want them to ask good questions, we want them to give constructive feedback, and we want them to help the surgeon come out the other end with an action plan or something they're going to change about what they do. And overall, the surgeons were pretty confident. It's because we had a bunch of white males here. Just kidding. The surgeon perceptions of the coach were that the coaches were actually even better than they thought. The surgeons thought that the coaches did awesome. Now, we also came up with an objective way to look at how the coaches did. And this was grading or rating by people who were experts in coaching and people that we trained on the way that coaching should go. And we didn't evaluate them quite as highly, but we tried to do this not on a curve. So we sort of said, okay, if a 5 is somebody who is a professionally trained coach, how are these people doing? And I think that after a 4-hour training session, if we can get them into the mid-range, I think that's awesome, actually. I think that the coaches were doing really, really well. And the thing that's great about this is that it gives us a pretty wide spread in terms of trying to dig a little bit deeper on what makes a good coach, what makes a good coaching program, and what is it about these matchings that might be important. So we performed different assessments on our coaches and our coachees. So things like trying to figure out how do we match people based on their personality profiles, or what is it about them in terms of their interpersonal ability to interact with other people that makes them either a good or not such a good coach. And then when it comes to program evaluation, again, I think these are telling numbers that, you know, on a scale of 1 to 5, surgeons rated their coaching session of 4.6 in terms of how valuable it was to their performance. So good responses, good perceptions, but for those of you that are familiar with Kirkpatrick's levels of evidence, this is pretty low evidence, right? But again, we don't have a ton of evidence for what we're doing now. But what we ended up with at the end of this program was we ended up with an intervention. So we ended up with a training program that we feel is really empirically based, because it was based on a lot of interviews, a lot of observations, and a lot of time spent reviewing the literature. We had preliminary work for a randomized controlled trial. We had proof of principle, we had feasibility, we had the evidence-based intervention, and we had some pilot data based on perception to support it, and a rubric for evaluating the quality of coaching. But we also had a lot of challenges with this program. So I think the biggest barrier to our program was scheduling. So the program was designed to include 4 longitudinal sessions, and we had nobody who could complete the program as scheduled. Some people tried to do different things, like they would bundle them up and do a couple of sessions together, but this was across the state of Wisconsin. It's very rural. We didn't want anybody coaching anyone in their same program, and we didn't want anyone coaching their immediate competitors in their same marketplace. So this means that people were traveling, you know, 3 and 4 hours to go and do a 1-hour coaching session, and that's really problematic given our time constraints. And then the technical approach for video review, we had lots of problems with AV capture, as well as the software for review. So we're continuing to try to improve on that. So the thing that we realized with scheduling was that what we needed to do was to integrate it with times that surgeons are already coming together. So we'll talk a little bit about how we're doing that. We need to do some experimental testing on the optimal timing and the optimal format of coaching. And then with the video review, if we want to do it now, limiting it to laparoscopic technical capture is probably the safest way, and that's how we got our R1 funded. But we're also partnering with industry, and there's actually quite a few people out there that have these portable AV systems that allow us to capture this, as well as software for video review. So now I'm going to talk about what we're doing in Michigan, which was the next step. So what we did was we wanted to evaluate the impact of a video-based peer coaching program on peer ratings of surgical skills. So thinking back to that Birkmeyer paper, can we actually narrow the variation and raise the bar for everybody? And to evaluate the impact on risk-adjusted complications. Now, no matter what I told them about what we learned about coaching, every bariatric surgeon there was in unanimous agreement that we needed to have all of our coaches from the top quartile. Everybody said, I'm not being coached by anybody who's below me on that graph, right? And, you know, I said to them, I said, come on, guys, we all know people who are great technical surgeons, but aren't exactly the person who you want to sit down and give you feedback, right? But that's what they wanted, so we did it. And the great thing is we got lots more variation there than we did in Wisconsin in terms of the abilities of the coaches and in terms of how they're assessed. The goal was for everyone to participate, and it was a step-wedge design, so we wanted people to sort of enter at a randomized time so that we could have a control group. So it was really successful. So our goal had been to enroll 30 surgeons. We enrolled, I think, 42 surgeons in the end. They were supposed to do 4 sessions. Many of them ended up doing 6 and 7 sessions, and they want us to figure out how to integrate this into their program going forward. They really liked doing it. And I think that there were a couple of reasons it was successful. Number one, it was limited in its clinical focus. So it was focused on bariatric surgery. And I'm going to talk about why that actually caused problems as well. It was based on laparoscopic procedures, so we got rid of the AV issues. We added it to existing meetings. So they already came together 3 times a year. So they just came an hour early for these video-based reviews. The surgeons that were engaged in the QI initiative were the same surgeons we wanted to participate in the coaching program. And they'd already been working together for a decade, right? So they had this level of trust. And they knew that they'd kind of gotten as far as they could with their data, and they were looking for new ways to improve. We spent significant time sort of promoting the project, and then, as I mentioned, there's this culture of trust because they've been working together for so long. So one of the problems that Danielle and I were talking about yesterday with our current approach to research is you submit a grant, right? It takes you a couple months to get the grant together, then you submit it, takes you a couple months for it to get reviewed, a couple months to get to council, maybe you have to resubmit it. So in between the time that we designed the program and the time we got funded, and somebody talked about this today during their presentations, we stopped doing gastric bypass and we started doing sleeves. So we were powered based on the complication rates of gastric bypasses, but the complication rates of sleeve is exceedingly low. So all of a sudden we lost our ability to actually link this to outcomes, which had been, again, what people keep looking for in terms of buying into coaching. So we have an ongoing evaluation. We're looking at mixed methods evaluations of coaching. We have exit interviews, we have clinical data, we have all sorts of stuff. But there have been a couple of things that have come out of this that I think are really important that we are looking for our next set of studies to address. The first is a dose response effect. So even though I told you that people kept coming back and kept participating in it, they actually were adapting what they were doing, because after a couple of sessions, the sleeve procedure isn't that complicated. So they didn't really need as many sessions as they would have if it was a bypass. So thinking about the complexity of the case and how many of these sessions make sense to do. The next thing is, again, what makes an effective coach and what we were right about, but also kind of what else can we identify that's specific to surgery. And then how is it that coaching is effective? So this is just a picture of kind of what it looks like when we have these sessions. The energy in the room is really cool. So you have a bunch of people, 10 pairs of surgeons all looking at video, drawing pictures, talking about how they would do things differently, how they do things now. It's pretty cool to see. This is the conceptual framework that we're using moving forward. This actually comes from a grant that I'm resubmitting in 2 weeks. But it's this idea that we're trying to break out and figure out, do we really have to do all of this? Do we really need this whole coaching framework? Or is it just that we're all so starved for constructive feedback that if we had a way to give each other feedback, we could do it in a more simple way? So we are proposing a randomized trial through the America's Hernia Society Quality Collaborative, looking at using time-stamped video-based feedback to full live coaching. And then the second piece is this issue of self-assessment. So looking at how people correlate with experts at baseline, and then once they go through the coaching program, that what they saw in Canada with the trainees, is it the same thing with surgeons in practice? So expert coaching, I mentioned that we did a little bit of work around expert coaching, and this was called Project Adopt. It was funded by Covidian, and the idea was to take surgeons who did other laparoscopic procedures and open hernia repairs, inguinal repairs, and teach them to do laparoscopic inguinal hernia repairs. We put together 3 different programs that already existed at the University of Wisconsin. So the first thing was people got a bunch of preparatory materials and then went through a very short didactic session. We then introduced them to a simulator where they went through the steps that they had just learned through their didactic session. They then came back and participated in a gloves-on program. And this is where they come and they actually scrub in at the University of Wisconsin and act as the assistant for an expert in the procedure they're trying to learn. Then that surgeon, who's their coach, who will ultimately be their coach, actually goes out and precepts them when they start doing the procedure for the first time at their own institution. They then switch into the coaching program where they continue to perform the procedure, but they videotape it and they review it with their coach to figure out how they're doing. And then once both the coach and the surgeon agree that they have reached independence, then they basically are finished with the program. And so the people that participated in this were people who had taken these weekend courses, who wanted to learn how to do it, but they weren't able to basically take what was taught at these courses and then go back and independently, when a patient's sitting in front of you and you know that you've done hundreds of open hernia repairs and you can do it safely and get the patient off the table, that you're going to instead struggle for 4 hours and do it laparoscopically, right? That's the problem. And so what this program was intended to do was to be there to support the surgeon through their first couple of cases. So, do 4 cases in a day, get the first ones under their belt, help them to teach their team how to do it, but then to have the video coaching that helps them to continue to improve, but in an independent fashion. So my closing comments. Coaching, in my opinion, has the potential to improve performance throughout surgical careers. It incorporates concepts of adult learning theory and coaching principles of co-learning. It offers novel opportunities for both learning new procedures as well as, and perhaps more importantly, performance improvement by addressing variation in performance, improving quality, safety, and outcomes. We are already investing a substantial amount of resources in the form of both time and money in CME. And existing organizations can support the infrastructure for coaching programs if we choose to go that route. And so one of the things that we're exploring is whether or not surgical societies are a home for this. So you can imagine that in several rooms you can have breakout sessions with didactics, but in other rooms you can have trained coaches sitting there with laptops waiting for you to come in with a video and review it and see how you could improve. But this requires a real cultural change, a willingness to open up and a willingness to commit to collaborative learning. Currently, we're really focused on autonomy. Right? We are autonomous practitioners. We practice in our own practice. Our learning is amassed, our evaluations are summative, and our goal is competence. What we want to do with coaching is to try to continue to evolve in the way that we have a new approach that allows us to focus on collaborative learning, individualized learning, formative evaluations with a goal of mastery. So this is obviously the work of many, many people. These are some of the team members that have worked on some of the projects that I've talked about. And I just in closing want to say that we're going to be having a surgical coaching symposium where we're going to try to do something very similar to something that you guys talked about doing, which is getting everybody working in this space together into a room so we can talk about where we're going, where we think the field's going, bringing in people from industry as well as people that are doing research, and using that as the launch of an institute for surgical coaching through the University of Wisconsin, where we can help to continue to train people and develop these programs. So with that, I thank you for your attention, and I'd be happy to answer any questions.